the heart rate, next 5 seconds axis, next 5 seconds, the P wave abnormalities is what we're going to focus on. And if you look at the configuration of the P wave, which is going to originate from the SN node, the initial part of the depolarization, or the initial part of this upright wave indicates the right atrial depolarization. And when you are looking at the downswing of it, it is representing left atrial depolarization. P wave per se is an upright wave. Height and duration has already been mentioned. That is less than 120 milliseconds for the duration, less than 2.5 millimeter for the vertical height. P wave is positive everywhere except one. If you look at P wave with respect to AVR, you will always notice that in lead number AVR per se, the P wave will turn out to be negative. I want to repeat the fact once again. AVR is one lead, where the first wave of the ECG and the last wave of the ECG, the P and the T wave, both are turning out to be negative. This is perfectly normal, guys. No abnormality. AVR tends to read the heart that way. The P and T are always negative. In contrast, if you are ever going to look at lead number V1 per se, and you're going to scan the P wave, you will notice it will be biphasic. Some part of it will be above the baseline, some part will be below the baseline. The part above the baseline is right atrial depolarization, the part below the baseline is left atrial depolarization. So the message at this junction is that P wave is always an upright wave, but can be negative with respect to AVR and can be biphasic with respect to V1. And now we will look at an abnormality. The abnormality is that the P wave of the patient is turning out to be rather wider than what is supposed to be. Why? Because the person is having a left atrial enlargement. I have drawn a P wave with a slight notch. Now this notch may not be visible in the actual exam because lots of time the ink blots on the paper, so the notch may not be very classical textbook kinds. But what you can definitely see in the ECG of this patient is a duration of more than 120 milliseconds. If the duration of the P wave is more than 120 milliseconds, that is about 3 small squares or more, then it is technically called as premitral. Well, what does premitral signify? It signifies that the left atria of the patient is dilated, so the current will take more time to go across this dilated left atria, and that is why they usually ask you premitral signifies. You just need to answer LAE, that is left atrial enlargement. In contrast, in some cases, they might even give you an ECG where the height of the P wave will be dramatically increased over and above normal. So if the P wave vertical height is more than 2.5 millimeter, we call it P-pulmonal. It signifies right atrial enlargement and is commonly seen with patients of pulmonary artery hypertension. So at the moment, I want you to remember two abnormalities of the P wave that I'm going to now show you in real time. You can notice a slight, I would say, bifid appearance of the P wave coming up. Actually, the point is, this is a classical textbook image, so fine. It might look to you that you can see the notch per se, but what I want to highlight here is the fact that lots of time in the exam, all you will notice is that it is the duration component which is going to be hampered in this particular case. And at the same time, the P wave amplitude, it's rather spiked P wave. No, I mean, I'll say P wave has more of a rounded configuration. You can notice the spike occurring in the P wave. That's because the height is relatively more. So the superior representation that I made before you is for P mitral, and the inferior one is for P pulmonal. And these are two abnormalities that must be always looked at. And following the P wave, always check out whether QRS complex is present or not. Because if it is present, it is normal sinus rhythm. If not, then there could be a possibility of heart blocks occurring in a person. I'll describe the heart block subsequently when I talk about the PR interval. Because coming up next is PR. Either PR can be short, therefore there could be tachycardias in a patient. If PR is prolonged, there would be bradyarrhythmias occurring in a person. So the objective at this particular point, the way we stand at this particular point is, we have learned the roadmap for the first 15 seconds of analyzing a ECG, the heart rate, the axis of the P wave duration, and check out whether P is followed by a QRS complex or not. And next, I'm going to talk to you regarding short PR interval conditions versus a broad PR, or rather a wide PR interval or a prolonged PR interval conditions. The next condition that I'll be explaining